Hey everybody, it's Paul Singh. I'm here with Nate Lighthizer, and we are so pumped to have you guys stay this whole time. You guys are like troopers, man. We did the last session of Eyes on Glaucoma. So first of all, kudos to all of you who are stuck around for the best session the best for last, right, Nate?
Yeah, that's right. Say the best for last, buddy.
You know it. We're going to talk about living the laser life, an OD-MD perspective. It's really not, let's say, OD versus MD perspective. It's more, how do we get really involved with understanding the importance or the benefits of laser treatments out in the glaucoma space? And that's going to be a lot of fun today. I can't wait to talk to you about that, Nate, and kind of your experiences and your practices and kind of what you've been doing out there as well. And tell us who you are again and where you're from.
Yep. Nate Lighthizer. I'm a faculty member at the Oklahoma College of Optometry in Tahlequah, Oklahoma. I've been down here for 13 years now. I went to Pacific University College of Optometry in Oregon, and then I did my residency in Oklahoma and joined the faculty ever since. I'm in charge of our specialty care clinic where we do laser procedures and co-manage things like that as well. So my pleasure to be here. Looking forward to it, Paul.
Awesome. Yeah. And I'm Paul Singh. I'm a glaucoma specialist out in southeastern Wisconsin. I'm a cheesehead, a little depressed because our Bucks actually lost yesterday to Celtics. That's okay. But anyway, I'm looking forward to hanging out with you guys. I do a lot of MIGS, a lot of interventional glaucoma. I think today we'll talk about how, I think for both of us, Nate, we've really, I think, changed our philosophy of really what is controlled glaucoma? What does it mean to actually have a patient who's kind of controlled long-term? And what does it mean to actually have a refractory kind of patient? So I want to talk to you about that today as well as we talk about lasers. And I know this is your disclosure list here as well, just for everyone's sake. And of course, I have my disclosures here. So we both speak and consult for a number of the companies in the anterior segment glaucoma space as well. But with that said, Nate, to me, by the way, I want to give a shout out to you because you actually had the coolest laser book that I was part of. So thank you for letting me be part of that. So if anybody's out there wants to have a book that just talks about lasers in eye care in general, Nate, what's it called again?
The Ophthalmic Laser Handbook. And it was written by retina specialists, corneal specialists, optometry contributing from co-management perspective, and the lasers that we do in the states that have that. Paul, obviously the expert on laser floater removal, wrote the vitreolysis chapter. So the Ophthalmic Laser Handbook.
I love it, man. That was a great book. I had a chance to read all of it finally. It was awesome. So well done to everybody. Anyway, with that said, good job for that. But, the toolbox has expanded, my friend. And I think we are so lucky now. And in the glaucoma space, at least for me as a glaucoma specialist, we have the lasers we'll talk a lot about today. We have MIGS, of course, and even drug delivery and new molecules. And I think to me now, we have so many opportunities to aggressively earlier address glaucoma, but yet maintain high quality of life, appreciate the impact of compliance on patients' quality of life. I think that to me has really been kind of exciting as well. And I kind of joke around. I kind of felt like this guy after glaucoma fellowship, man. I did my fellowship at Duke back in 2004. And I came out and I would go out to meetings and we're like, you're glaucoma. I'm sorry, dude. They feel bad for me. But then like MIGS came out and all this new SLT and laser studies have come out now. And all of a sudden I kind of felt like this guy where like everyone wants to hang out with me. I'm like a popular guy. Girls like me now. It's like, this is kind of cool, man. So yeah, I got to give you some credit for that. But it is exciting time. And I think the impetus, and I'd love to hear your thoughts, Nate, on this, but to me, probably the biggest issue I face in medical management of glaucoma truly is compliance. I mean, I think it really is hard. I mean, tell me about your experiences with how to maintain compliant patients, man. It's tough, isn't it?
It's difficult. I mean, we all battle that when you put a patient on a drop for a largely asymptomatic condition. They don't know their pressure is 24, 25, 26, whatever it is. And even if they have the best of intentions and they're taking that drop night after night or day after day, who knows if they're getting it in the right way? They may be spilling it onto their nose. They may be missing their eye. So, I mean, we battle compliance, cost issues, just convenience in our active patients, our younger patients, but even our older patients are more active now. So compliance, it sucks, as you said.
And you mentioned earlier, Nate, I mean, these are the kind of things we see, right? Whether it's costs, side effects, forgetfulness, you name it, there's adverse events. And so because of all these issues we face, we're constantly not understanding why are people getting worse? Why are some people progressing despite at the time of their visit having quote unquote controlled pressures? And their fields may not look obviously worse, but it's a matter of time. We get fooled in glaucoma so quickly and so easily. And I tell you, if you ever want to have some fun and you're bored in your practice, just in general, give a patient, before you prescribe a drop, give a patient an artificial tear. Say, look, in the office, just take your drops and see what happens. And you can be amazed of what people will do to actually get their drops in their eye. It's kind of scary what people people do. And so I've seen Alan Robbins got some great videos out there many years ago, but it's really funny and it's scary to see how people will put their drops in the eye and how much they contaminate the tip, how many drops come out at one time. That's why they kind of run out of medications much more quickly, than their prescription will be refilled, and they start to skip drops. And there's so many reasons why it's so difficult. And, we know this too, that not a lot of our drop actually gets absorbed in the eye, right? Only 5% of the drug is actually absorbed, about 50 microliters you put in. But again, very little is actually absorbed because of the conjunctival penetration or absorption, the lacrimal system as well, corneal absorption, blinking reflex waters the eye down. I mean, there's a lot of reasons why drops are not always effective. But I'd love to hear your thoughts on this, my friend. I tell you, one of the other biggest comorbidities that I face in medical management of glaucoma, dry eye, ocular surface disease. It's the biggest comorbidity. Love to hear your thoughts. I mean, these are studies that have been published showing us that 40 to 50 to 60% of our glaucoma patients have a concomitant ocular surface disease. Do you agree with that? And what is the impact in your practice?
I agree, Paul, and it's a huge impact. It's dry eye all day, every day. Doesn't it seem like that all the time? And then you've got the glaucoma patient it's in there as well. And we're helping the glaucoma, lowering the pressure, but yet we're exacerbating the ocular surface disease, the dry eye, the MGD. So it really is a battle that we all face. And that's why I think drug delivery, laser procedures that we're talking about specifically are really ideal for a lot of these patients.
Absolutely. I mean, you think about everybody out there, right? There are very few other conditions in the eye that have as many associated symptoms as ocular surface disease. Think about it: tearing, burning, pain, redness, photophobia, fluctuating vision. In fact, in a study we did many years ago in our own practice, we found, non-published, we found that the number one symptom that actually contributed, or that was a risk for developing dry eye, or that helped understand the impact of dry eye, was fluctuating vision. If someone came in and said, my vision comes and goes, I have to blink my eye to clear it up after reading for 5 minutes, or I have to blink my eye when I'm driving and kind of clear up the glare, that's an ocular surface disease or tear film instability. So even if you don't have a lot of the diagnostic tools, and we get so caught up in a dry eye center of excellence, do you have MMP testing? Do you have osmolarity testing? Do you have all the different topographers and scans to look at the meibomian glands? Even if you don't have all that, if you listen to the patients and they say, hey, doc, my vision's coming and going, that's a patient who just address it and understand that we can do simple things we'll talk about, whether it's getting them off the drops, treating their ocular surface disease, can really impact them, because I have found that patients trust you better when you acknowledge their symptoms. So if they're coming in and you're like, yeah, but your pressures are great, see you in 6 months. But they're like, yeah, but doc, I can't see every day and my vision's coming and going, and you don't address it, they tend to not trust you. Do you notice if you even address the ocular surface, Nate, that you find patients just like, oh my God, you're the first ones that's told me that now I know why I have my symptoms. Does that happen to you?
I find it all the time. Patients would rather you talk about their symptoms, give them a little, tender, loving care in the exam chair, whether it's dry eye, whether it's floaters. I spend more time with my patients with floaters, talking with them, and they love it to be able to, yes, you're the first one that's really talked about and cared about my floater or my dry eye or whatever it is. So those conversations are very important, and it really wins you over a patient, their family members, your friends. It's a practice builder.
I'm totally with you, my friend. And we look at other data sets out there that shows us that, guess what? The more bottles you add, especially with BAK, the more risk you have of developing glaucoma, dry eye in that glaucoma patient. So this is why, even if you have, let's say you start someone on a PGA, right? And that's fine. But then you start to say, let me add a second or third bottle. Not only do they start to decrease their compliance, if you look at data on compliance, Fechner's shown that very clearly. You add that second bottle, you go down by 50%, but then you also add more ocular surface potential as well. So it's like a double whammy. Not only are they going to forget, not wait 5 minutes between drops, but on cost becomes more of an issue. You add that second, third bottle, but now you have a higher risk of developing ocular surface disease. So before I start to add a second one, that's really where, even if the patient doesn't want to do an SLT first line or any kind of intervention first line, definitely as a second line, I'll say, hey, before we start adding more drops for you, Mrs. Smith, let's consider something different, like a beam of light, or like the drug delivery, or MIGS as well. So I'm not sure about you, but I think even if, a lot of colleagues out there may not be comfortable with a first line, laser, let's say hypothetically, but I think a second line is a great opportunity for some of those who are a little bit more conservative about laser. What do you think?
I would agree completely. To me, at least in my clinic, when you would just ignore all the studies just from the clinical trenches, compliance just tanks when you add that second drop. They can maybe handle the first one, but that second drop is usually pretty bothersome. They forget, they don't get it in. So I'm a big believer of SLT earlier in the course of therapy. We know it likely works better earlier in the course of therapy. So I think it's time to change our way of thinking and go earlier and earlier.
Love that idea. And why is this so important? And we keep harping on ocular surface disease a lot, but it's because it's so common. But here's the impact. Look, Bedouin has shown us a 30% reduction of compliance if you have a concomitant ocular surface disease, right? 90% versus 60% basically. And that is the key, right? We need to have people who are compliant, because what happens if you're non-compliant, you potentially have a higher risk of fluctuating IOPs. And so, yeah, you may be fooled. The pressures are doing great. You think, wow, okay, the pressure's the way I want it to be. And then they go home and don't take the drop, right? And all of a sudden the pressure going up and down, up and down. And that in itself can be a risk factor for progression. In fact, I'm not sure about your thoughts, but I think to me, I think that's something where, especially when I get more advanced patients, where I start to really worry about fluctuating IOP. I mean, are you concerned about fluctuating pressures in your practice?
Yeah, the more they go up and down, the literature has shown us the more fragile the eye. That's really going to affect the nerve fiber layer, visual field progression. So fluctuating IOPs, and that's one of the big reasons I'm a believer in SLT again, is because it's shown that stability of that diurnal fluctuation up and down. So yep, that fluctuation is an issue.
Now, real quick, not to harp on dry eye so much here, but I'm just going to show you a video here. I know a lot of my colleagues, a lot of our colleagues rather, would say, hey, DePaul, it's hard for me to detect surface. I put the fluorescent in the eye. It's really hard for me to see ocular surface disease. And I'm just going to show you a quick video. I'm not sure. Do you use a Ratten filter? Have you heard of the Ratten filter? Do you use that in your practice at all?
Yep, we do. Yep.
I have become a huge fan of it. In our slit lamp, we actually have an automatic little button that can switch back and forth. But if you don't have a filter in your slit lamp, they come like in Amazon sells them for like $15. There's a yellow filter you can put in front of the slit lamp there, and it can really highlight. It's just an example of a video that's showing you when you have a filter. This is a blue cobalt blue light. You put that filter, look what happens. I'm here. There's some EBMD, some decreased teal film there, some SPK, and you really can't see it with the cobalt blue light there. But if you put that filter on, all of a sudden it's like, wow. So there's a lot of patients I was missing. You see these patients coming in saying, doc, my vision's coming and going, or I'm not seeing clearly. The 20/20, the chart. You're like, why are you complaining? You do this. You're like, whoa, okay. I didn't realize that. So there's a little bit of a pearl there. If you're really having a hard time detecting OSD, whether it's a tear film or EBMD or even SPK, try this filter. It's really helped a great deal. But to Nate's point earlier, we talked about studies that have been published looking at fluctuating IOP and what that can lead to. This is why I'm so passionate about addressing compliance. You talked about Bedouin showing us 30% reduction of compliance. Well, if they are not compliant, the pressures are fluctuating, especially the more advanced we get, the more risk we have of progression in terms of field progression. This is the AGIS, the Advanced Glaucoma Interventional Study. And long story short, on the left, you see here, and the blue means you fluctuated about 3 millimeters of mercury or less. In the red, you fluctuated more than 3 millimeters of mercury. The bottom line is if you fluctuated more in the red, you see over 100 months, you have a higher risk of visual field progression. But here's the killer. This on the right side is what I want to show you. This literally was like, bing, holy cow. Check this out. In Caprioli in 2008, looked at a post hoc analysis of the Advanced Glaucoma Interventional Study. And he basically did a subgroup analysis. He grouped patients either who had a mean of IOP of 10.8, so basically 11, which is really hard to do, versus a pressure about 20, okay? Now, in that group, if you had a pressure of average of 11 for the course of the study, but you fluctuated less than 3 millimeters of mercury, or 3 or less rather, you had a 9% chance of progressing over time. If you had the same mean, but it fluctuated 4 or more millimeters of mercury throughout the study, you had a 30% progression chance. Incidentally, that was the same progression as if you had pressures that were high and fluctuated. So when you get the more advanced we get, the more we start to see the impact of fluctuating IOP. So that's why if you have a patient in your office, you're like, why are they getting worse at a pressure of 11? Maybe consider doing a diurnal curve. I'm not sure if you do this all, Nate, or having them come back at different times of the day. And you may say, wow, you know what? There were 12, 12, 12, then all of a sudden 15, 14, then to 10, then 12 again. Have you seen that happen in your practice?
We have, where they'll have pressures that are 5, 6, 7 points different than what we thought they were because they're a morning patient or they're an afternoon patient. And that's because of work. They want to be in the afternoon or the morning. And then we say, all right, let's get a different pressure, and it will surprise you from time to time. And that's going to be a red flag when you see that big difference, as you just said.
Absolutely, man. So this is the kind of stuff that really, it kind of scares me. Now, here's something that's really interesting, right? We talk about the oats study, man, and people kind of like, yeah, whatever, oats, big deal. Yeah, we know you treat them, 5% chance of getting worse, 10% if you don't treat them, right? That's been there, done that. Corneal thickness measurements were obviously important there too as well. But this is really interesting. If you look at the slope of the progression, right? So blue is if you did not treat medication treated patients, again, 20% reduction, not a very aggressive. But if you look at the slope here, at up to about 50 to 60 months, the slope of progression between the two groups maintained itself. But look what happened at 60 months, 5 or 6 years later, look what happened. That slope went way up. This is the problem with glaucoma, structure function. We talk about it all the time. It's just takes time. If you're old like me now, I've been around for 17 years after fellowship. I see this, man. I feel patients who are like, yeah, the pressures are good, they're good, they're good, or they're borderline, they're going up and down, but their fields look fine. And all of a sudden, one day they come in and you're like, okay, what just happened? How did they get that field loss that was completely normal? Has that happened to you yet? I know you're pretty young, but
it has happened, and it's a panic type. When you see that and you go, I thought you were controlled. You thought you were controlled. What did I miss here over the course of the last, few years? And it's this exact point that you're identifying. And that's why we just need that stability and that diurnal control.
So let me ask you, look at these pictures of PGA patients. Question to you and our colleagues all you guys out there hanging out with us today. Truly, if you think about it, we'll talk about the SLT. We'll talk about, kind of complications and adverse event risks. But if you look at these risks, are these benign? What do you think?
Definitely not that bottom center picture. I'm like, holy smokes. That patient would be miserable there. The bottom left one certainly is one of the most common ones that we see. And I can't tell you the number of patients that I've said, Doc, my eyes are red. I know these drops are helping, or at least you tell me they're helping because my eye pressure is lower, but I don't like the way my drops are looking. I had a female patient that was a realtor a number of months ago, and she stopped her drop. She said, I got tired of my clients asking if I was smoking dope all day long because my eyes were red. So, you nailed it, Paul, with all these potential adverse events.
So just think about it, guys, and I'm not here to say drops suck. Look, we all use drops. We need drops, and it's not like a drop bashing session, although I don't mind bashing drops sometimes. But, it's to be aware that these are real. And whether it's fat pad loss, whether it's thickening of the glands, even the BAK-free PGAs have the risk of causing MGD, whether it's allergic conjunctivitis, whether it's hyperemia, which does decrease compliance and based upon studies, whether it's lash growth, hyperchromia, there's a lot of issues that can happen still. And again, they're not always the same in every patient, but they can happen. So before we get into the whole SLT world right now, because I know we are going to talk about laser, I promise. But before we get into that, have you redefined in your practice, or how do you define controlled glaucoma?
So it's a variety of factors. To me, it depends. It depends on the age. It depends on their severity. It depends what's the IOP, what's the visual field, what's the optic nerve, all these different things. And I'm looking going, how old is this patient? If my patient is 98 years old and, they're probably not going to have many years left, that may be different than if somebody is 58 and the same severity may not be as controlled. So it's a variety of factors that we look at.
I'm with you, 100% agree with you. And look, the heart and soul of my definition of controlled glaucoma, no doubt, are the pressures where I want them to be, are they at target, are the field stable, are the optic nerve stable on exam or on OCT, right? No doubt. Don't want to minimize that. But I do now take in quality of life as part of my definition. So if I have a patient like this, that is someone, regardless of how the IOP is that day, regardless of whether the fields are stable and normal, if their patient comes in looking like that, what is the chance of that patient staying on that regimen long term? If it is low, in my opinion, based upon what I'm seeing or their history or their complaints, then that is a patient who's not controlled, because it just takes time. Eventually it'll kick you in the butt and you'll realize, oh shoot, I should have recognized it. So this is kind of my new philosophy of when I say controlled glaucoma. It's a combination of all those things in the first section, but with quality of life added to it. So I'll actually have patients in my chart who I'll say, recommend SLT, recommend MIGS, recommend surgery based upon patient's quality of life, uncontrolled based upon an ability, blah, 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 even if the pressures are stable. So that's kind of my new philosophy as well, which gets us to, finally, SLT. And really, we have a lot of different lasers. There's obviously ECP, was micropulse. Just for the sake of time today, we're going to focus a lot on SLT and compare it to like ALT. But I think there's a lot of lasers out there, and for the sake of time, we'll focus on this. But tell us, Nate, and you're so well versed on lasers. What is an SLT, and how does it differ from ALT in your hands and your opinion?
Yeah. So, SLT obviously being a frequency doubled Q switched YAG laser, we were just training some doctors across the country, and we always tell them, the green laser, the photocoagulator from ALT is 532 or around there. And so is the SLT, but yet they work so differently. And it all becomes down to that pulse duration of 3 nanoseconds. It's so quick that the pigment cannot absorb that laser energy, convert it into a burn. There's no structural or minimal structural damage. And you just get that inflammatory response, that biologic response that we talk about. I explain it to my patients, Paul. I always say, think of your eye like a sink. They come in, okay, I'm having a laser. Is this going to improve my vision, doc? No, it's not that laser. It's a different one. This is for the glaucoma. I say, think of your eye like a sink. There's an area where the fluid is produced. There's an area in the eye where the fluid drains. It's often a drain problem in glaucoma. This laser is going to work on the drain, and actually your own body is going to do most of the work. The laser is really just a beam of light. It's going to put a little stress on that little drain. And when your body is stressed, what fights that? Your immune system does. And it's going to come in there and it's going to start cleaning up all of the debris in the drain. That's how I explain it to patients. They just seem to get that. But it really all comes down to that pulse duration so quickly, no photocoagulative damage to that drain. Unlike ALT, which, as you know, Paul, damage to the meshwork. And that's why the repeatability relatively poor, wasn't it?
Absolutely, man. And you made some really good points. I want to just take a couple minutes to talk about that. So you said the word beam of light. So one of the pushbacks I get from a lot of colleagues, whether it's ophthalmologists or optometrists, who say, hey, I don't feel like offering SLT because my patients get scared of the word laser, right? And the way, I love how you described it. The way I describe it is very similar to you. I say, Mrs. Smith, your eye's like a water balloon. It's hollow inside, but it has to maintain a certain shape. So it creates water to keep that shape, but it has to drain through a small little drain. Your drain's getting blocked. I have a beam of light, just like you said, a beam of light that stimulates your natural drain to release your own enzymes to open the pores, to rejuvenate. It's a rejuvenation laser. And that rejuvenation beam of light, and it's covered by insurance, takes about a minute or two in the office. You see those key factors: covered, in the office, rejuvenation, beam of light. All of a sudden, the patient's like, yeah, doc, why would I not do it, right? If you start off by saying, I can do a laser to treat your glaucoma, they think, oh, crap, laser, cutting, LASIK, that kind of stuff. So I think you made a really good point of how we describe it, the confidence that we describe it. And you made a great point. It's non-destructive. And this is important. We talk about, let's say, MIGS. We talk about going into the conventional pathway and opening up the canal with viscodilating procedures, et cetera. If you have ALT and you're starting to cause burns that cause coagulative damage, which we'll show you here, then you have the risk of, let's say, going in to do a canal dilating and having a difficult time because of those laser burns as well. And so being able to repeat it is important, because we do have many studies, we'll show you in a sec, that show us that when we can repeat, you can repeat SLT a number of times over. Now, sometimes you do get a little bit decrease in the efficacy after you repeat it, but even after previous ALT, you can repeat SLT on top of previous ALT because it is non-destructive. And you made a great point. It's causing really a release of this whole cytokine interleukin macrophage MMP9 or MMP rather cascade. So tell us about that. Like, what's happening? It's the macrophages pretty much?
Yeah, I call them the trash collectors to the patients, but the cytokines, the macrophages, cleaning up all of that subcellular debris. We're not going to see it as clinicians. I'm not going to look at the TM a week later or a month later and going, oh, look how cleaner it is. That subcellular debris that enhances outflow. And again, it's an inflammatory effect. So works very, very nicely. And in theory, shouldn't we be able to do this again and again and again, unlike the mechanical effect of that photocoagulation from ALT? And I really believe, Paul, and we may get to this a little bit later, we may change our paradigm as we go forward, because to me, doesn't it make some sense to do this maybe more often, maybe a lower power annually or every other year? We'll see where that goes based on the results of the COAST trial, among others. So
Tony Riolini and his group are doing some fantastic work, 0.4 millijoules every year, looking to see, hey, you know what, instead of doing once and then waiting until it kind of rises and then doing it, if we just do a yearly kind of maintenance dose, can we keep that inflammatory cascade going on, allowing us to have a really stable IOP long term? So I'm excited about the COAST trial. I'm glad you brought that up. And we're going to go through some data here. Of course, the LIGHT trial that came out a few years ago from Gus Guzlar's work really helped a great deal. But I want to just ask a question, and more of a theoretical question. We do know that SLT, and we'll talk about data in a second here, that SLT does have a therapeutic value in terms of bringing the pressures down, getting people off of medications. But I'm going to talk to you a little bit about later on in this talk, but how I think there's a diagnostic potential. And what I mean by that is when you're looking, Nate, at your gonio prism, or anybody out there, you look at that beautiful view of their angle, you see a nice TM. Where is the resistance to outflow? Can you tell? Is it the TM, the canal or distal channels?
It's hard to say, isn't it? I mean, it could be the level of TM. It could be Schlemm's canal. Is it even the collector channels? It's very difficult to say.
Absolutely. So I think SLT, in my opinion, gives us, and I'll show you some data why I'm saying this, gives us a little understanding of maybe where the resistance to outflow is. SLT works 80% of the time based upon multiple data sets, but 15 to 20% of the time may not have the efficacy you want. But why is that? Assuming you did a good job, could it be because SLT works at the level of the pigmented trabecular meshwork like we showed you? But if they have canal dilation or canal collapse, or if hypothetically the distal channels are atrophied, then it doesn't work as well. So if it doesn't work, does that tell you, hey, when I do my MIGS procedure, if I refer for a MIGS procedure, maybe that's going to tell the doctor, hey, do something with the viscodilation because it didn't work well with SLT historically. So it kind of helps us to guide where the resistance might be. But before we go into all that stuff, let's talk about the basic data sets. You know, I think we've seen a resurgence in SLT and excitement again. And we kind of knew this for many years that first-line SLT work. But Nate, just if you don't mind, just go through some of the key points of the LIGHT trial that was just recently released a couple years ago by Gus Guzzard and his group in Europe.
Phenomenal study. And I always start when I say, okay, I always start with the SLT med study, which is hard to believe 12 years ago, Paul, out of Will's eye. That was really one of the first big studies in the United States to directly compare SLT with prostaglandins and found no difference. A couple of downsides of the SLT med study where the N numbers weren't huge and it was only a 1-year trial. So the LIGHT study, great big study, 320 to 330 people down each arm, the prostaglandin arm and the SLT arm. SLT is primary therapy, 3-year study, and they looked at a lot of different things. They looked at quality life, as you mentioned before, IOP reduction, and they found that SLT was just as good, if not even a little bit better in many of those. And to me, the key data point from the LIGHT trial was you look at it, 78% of patients were drop-free at the end of the study 3 years in. So I tell my patients that now. I actually quote that and I say, we've got a 75 to 80% chance. We got 2 great options for glaucoma. We've got eye drops. We can go down that road. We've got this beam of light. We can go down that road. If we decide to do the SLT, that beam of light, we've got about a 75 to 80% chance that we can keep you off the drops for the next 3 years. And the good news is it's repeatable after that, as you've said. So quick synopsis of the LIGHT trial.
Absolutely. And I think to dovetail off of what you said, the key for me also is the fact that 0 patients in the SLT group progressed to needing incisional surgery, like a trab or a tube or something else, versus 11 in the drop group. That's huge. That's a surrogate for progression, right? But if you look at also visual field, even deterioration, looking at visual field, less progression in terms of field loss compared to patients who are on the drops. Again, eye drops in green, orange is SLT. So that's, I mean, not only are we helping decrease the drop burden, saving cost to the healthcare industry based in Europe, at least in the study, we're also preventing more patients from progressing to needing incisional surgery or having visual field progression. So we finally see that. And the key to your point you made is that the IOPs were similar between the 2 groups, drops and SLT, but less drops needed in the SLT group. So if their pressures were the same, you had that significant difference. Why is there less progression potentially? What do you think? What's the explanation for that?
Compliance. It's got to be.
Go.
I mean, that's
back to compliance, baby.
Going, why did and these patients were primary, but they were just diagnosed with glaucoma, and still 11 of them needed surgery. Why were they progressing rapidly? Because they were not taking their drops. It goes back to that compliance.
And fluctuating IOPs. And to your point here, we have other studies. I just want to briefly, you know, we love the LIGHT study. Thank God for, and thank, you know, Gus and his work. But yeah, he's not the only person who's done this. It's been done for years. McIlrath has shown us many years ago, back even in 15 years ago, showing us that latanoprost versus SLT, similar IOP. To your point, the med study here with Katz's data, showing us no significant difference between SLT and latanoprost, of course. Very similar IOP reduction as well. And we even have, you know, Melamed and others showing us the long-term over 18 months with SLT as primary treatment, showing us good response. And I think a study that was really well done, again, Lada Ajindra, who this was at the one of the earlier AAO meetings back in 2007, showed us about 5-year data with first-line SLT, showing us really good control. So I think the earlier we treat, we're finding these earlier SLT studies showing us we have good longevity versus the original SLT studies in the glaucoma laser trial with this ALT many years ago showed us that they maybe lasted 6, 8 to 10, 12 months, or even 16, 18 months. Why do you think there's potentially more longevity the earlier we treat? What are your thoughts?
So I think there's multiple reasons for that. And I always when I talk to the doctors, I always say, show of hands, and I want you to be honest with me. How many of you have been disappointed in the effect of SLT before? And there's always a number of hands that go up. And that I use that as a discussion of your predictive factors for success. And I'm saying if you utilized SLT as your fourth drop replacement or your third drop replacement, well, what works better to lower pressure, Paul? Your first eye drop or your third eye drop? We all know you get better IOP reduction with your first eye drop compared to your third one. If you're using SLT as a third drop replacement, you shouldn't expect any more than you should from your third drop, which certainly is not going to be 25, 30, or 35% pressure reduction. Using it earlier in the course of therapy, and that's when you get your better bang for your buck. And the literature, as you've just went through, Paul, I tell people it's overwhelming now that SLT is first-line therapy, or it should be an option as first-line therapy.
I love that. And getting to the kind of the geeky part of it too, as well. That was some great points you made. And getting the geeky part of it, if you think about it, right? If you have long-term, let's say specifically diversion of, so your PGA. Now we know some PGAs may work at the level of TM, that's true, but majority of it works in the uvascular pathway. Let's say you put them on a timolol also, or Combonic or some other drug. And guess what? That's your second line, third line agents, you're decreasing aqueous flow into the TM. So what theoretically can happen? Well, the TM gets less flow, it can collapse more. When the TM is not seeing the flow through it, guess what happens to the canal? Theoretically, the canal can collapse. If the canal collapses, what happens to the distal collector channels? They atrophy and collapse as well. So there's a theoretical negative feedback loop. If we keep using aqueous suppressants or keep diverting fluid to the uvascular pathway, there's a chance that we may be causing further progression of that outflow resistance, especially distally, which is why, to your point, may not have the effect. So I think we have a number of reasons why, to your point about the first, second, third drop, as well as maybe the kind of the biomechanical issues as well, and the kind of the more histopathological reasons. And here's a great data by Lee in showing us too, this whole nocturnal, we talked about fluctuating IOP. I mean, you mentioned earlier that kind of flattening that curve, is that important to you in these SLT groups too?
Yeah, if we can flatten that curve and not have that up and down and keep them stable, again, that's a betterment of progression, a lessening of progression, as we said earlier.
Absolutely here. And just a real quick about adjunctive therapy. This is Latino, who's one of the founders of and the inventors of SLT, showed us that actually we do have significant, about 70% of eyes actually have a pretty significant reduction, about 3 or 4 millimeters of mercury reduction when added. So it can work as an adjunct. So we don't think you can't do it, but the response tends to be better as a first line, no doubt about it as well. And this is just a little brief, laser video I have here. And Nate, do you want to just talk to people about what makes it so much easier than ALT, that spot size? I mean, and the gas bubble or the champagne bubbles. You want to talk about that real quick?
Yeah, you got a great big spot size, 400 micron spot size. It's fixed. You don't have to change it. And you just cover that TM, that trabecular meshwork. Make sure you're especially over that pigmented TM, because SLT is selective for pigment, and you're looking for those champagne bubbles or cavitation bubbles. That feedback, shouldn't see any major blanching in the TM. Unlike ALT, you may see some of that. Paul, I'd be curious, what's your tissue endpoint? Are you looking for champagne bubbles every time? Is it 50 to 75% of the time? What are your thoughts?
Once I see the champagne bubble, I stop. I don't go up and up and up and just until I get every one. Whether it's 50%, 30%, I'm like, once I get that champagne bubble, I know that's the power I need. And absolutely, the more pigmentation you have, like a pigmentary glaucoma, pseudo exfoliation glaucoma, you turn the power down because you get those champagne bubbles at like 0.3, 0.4, right? So you want to prevent, and if you go crazy trying to go higher and higher, powers to get everyone, you might be overdoing it and you may get some pressure spikes. So that's kind of what I do. I'd love to hear your thoughts and the powers you use.
Yeah, so I start at about 0.8 millijoules when doing this. That's just a ballpark setting based on pigmentation. Obviously, we're going to do gonioscopy prior to the procedure. More pigment, turn it down. Less pigment, turn it up. I titrate about the lowest energy that produces champagne bubbles about 50% of the time. That's what a lot of the literature out there says, kind of right at that threshold of those bubbles, as you said.
Absolutely. And I think we're running out of time here, so I kind of took some more time. So I'm just going to fast forward this through real quick. But the reason why I brought this up is because when we look at why SLT may not work is because, and this is Haiyan Gong's work, which really was amazing at ARVO, showed us that 50% of our patients who are POAG have a complete blockage of the ostia of the collector channel. So if you look down on the left there, at top left, that's a Schlemm's canal, the collector channel openings there. On the bottom is a typical glaucoma patient where the canals collapse. So this is why if we wait and we don't know where the resistance to outflow is, we do SLT. It may not work in every patient. That's okay. But does it tell us that, hey, if it doesn't work, maybe the resistance is beyond the TM. Maybe it's in the canal. And I'm just going to fast forward here, but I want to show you some interesting iStent data. Many, many years ago, with the first generation iStent, after my first 100 generation 1 iStents back probably like 8, 9 years ago now, I looked at my outcomes and we found that we had really good response with the iStent. But what was interesting is that we had a subgroup analysis of about 30 some patients who had previous SLT. In that group of SLT, bottom line, the people who responded well historically to SLT tended to have better outcomes with iStent than those who had a historically worse outcome. It doesn't mean that SLT, that iStents weren't worth it if they had poor SLT response, but we did see a slight difference. And so that was the first clue that maybe the SLT gives us an understanding of where the resistance to outflow might be as well. So again, we don't know for sure, but those are the kind of reasons why I'm thinking it might be a good clue to understand where the resistance to outflow is. And I think the patient selection, real quick here before we get into some of your cases, my friend, is just what makes it so unique is that it's so universal. If they have an open-angle glaucoma, pretty much they could be a candidate, pretty much, right?
POAG, ocular hypertension, your top two indications. And there's literature out there, and it is debatable back and forth, but one of your biggest predictive factors for success being pre-laser IOP, the higher the IOP, the more bang for their buck. Again, that's why POAG and ocular hypertension are usually going to be your top two indications. Certainly low tension can be in there as well, but you're probably not going to get 25, 30, 35% pressure reduction. There's a literature out there, meta-analysis from 2015 showed about 14 to 16% pressure reduction in low tension. That's a benefit. We know every millimeter of mercury matters, and you go back to that diurnal fluctuation. So there's a benefit even in low tension and some of the secondary glaucomas as well.
Yeah, I mean, it's combined mechanisms. Post-LPI, I've done this on there. People have steroid response to exfoliation, works really well. Pigmentary, we think it's really a TM-related disease. So absolutely options for those. Talk about risks real quick here before we get into your cases. I mean, are there significant risks, and what are you finding in your practice?
So, I find this is one of the safest procedures we do. Certainly the risk of IOP spike is there. It's probably the first thing that we think about. It's still going to be relatively rare. I'd say under 10%, maybe even under 5%. The more pigment that they have, your pigmentary glaucoma patients, your pseudoexfoliative, you see probably a ton of those, Paul, pseudoexfoliation. I spent 3 months at Mayo Clinic during one of my rotations.
We Scandinavians here, man.
Oh, man. We don't see them much down here in Oklahoma with our Native American population, but man, we saw a ton of them up in Minnesota. But they're just more fragile anyway. So you may want to dial the energy down if there's a bunch of pigment. I always tell patients, we want to walk the inflammatory plank. We want some inflammation, but we don't want too much inflammation. If we get too much, then we could have that pressure spike. So that's certainly the thing you look at. But inflammation is how this laser works. You're going to have a little bit of that. I had a patient just a couple of weeks ago that had a little transient corneal edema. I've seen that just a handful of times. That's pretty rare. Overall, pretty safe procedure, right, Paul? The rewards far outweigh the risks.
Absolutely, absolutely. And so I think it's just important to understand that as well. Love to get your thoughts on NSAIDs. I was never an NSAID user, but then recently there's some studies about a few years ago that showed us that maybe using an NSAID might be beneficial. So I use like a Bromfenac once a day for about 5 to 7 days, just to kind of calm that inflammation down enough where they're not having pain. But yet it's been shown I've been having great results with that. How about you?
So same thing. I was trained on either give them nothing or an NSAID as needed. I've heard some, surgeons say if their eye is red and achy afterwards, good. I want it red and achy afterwards.
They're painful. yes.
Yeah. The SALT trial, among others, the steroids after laser trabeculoplasty trial said, NSAIDs as you described, or even a steroid for a few days after, probably not wrong with SLT. One other comment I'll have on this is the lack of efficacy. I put it on every consent that we do, regardless of the procedure, is this may not work. And it doesn't work in everybody, and you may need further treatment from another surgery or something like that, more eye drops. So not every procedure works in everybody.
Yeah. And I didn't mention here, I've had a couple of patients with CME in the past transiently that went away because of inflammation. So look, nothing is perfect, but compared to what we have, it really is a great safe option. So for the sake of time, I think SLT is a great option first line. If you don't feel comfortable doing it, or if you're, let's say, ophthalmologist or optometrist doesn't have access to it right now, that's okay. But think about it. Maybe refer out if you need to, because you'd be amazed of how happy patients can be. But for the sake of time, I'm going to move forward here and show one of your cases. But this is one of my pre and post SLT dry eye patients, just showing you on the right post SLT how much of a difference that surface can make. It's really, really incredible here. But last thing for me too is we did a study showing us when you take a patient off a drop, we saved about 4 minutes of tech time per patient per visit based upon callbacks or verification are they on the right medications, do they need refills, et cetera. So nowadays with all those FT issues with having difficulty getting good trained staff, we don't want to have them spend time trying to get patients drops and callbacks. Not fun as well. And my new therapy, kind of my new paradigm now is laser first often. If I can, of course, people sometimes do drops instead. I'll do MIGS early on and then do more laser, micropulse, ECP, et cetera. I'll still do a trab and tube if I have to, but drug delivery medications are there all along. along throughout the paradigm. So it's not always drops, then laser, then MIGS. It's really kind of varying now with the kind of SLT and MIGS early on like I used to. For the sake of time, though, I'm going to move on to kind of your cases here as well.
Yep. So this is a 58-year-old male, and it's a loved one. This is actually my father-in-law. My wife is an OD as well. So her dad comes down for an exam. He's got a family history of glaucoma. His mom has glaucoma, and he comes down for an exam, and he's 58 years old at the time, fairly young, right, Paul, for glaucoma age, and his pressure is 28 in the right eye and 25 in the left eye. Again, he's 58, and his mom's got, pretty significant glaucoma as well. I want to go to the next slide here, and you take a look and his visual fields. We took a look at his OCTs. Look at those center points on that right eye visual field. Not good at 58 years old. Again, pressures 28 and 25, family history, visual field, OCTs on the next slide. And I told him, I said, Ken, you've got, glaucoma. I watched him over multiple visits because we all know glaucoma is a progressive optic neuropathy. And I looked at him, I said, Ken, we need to lower this pressures. And this was in 2011, Paul. And I said, we can put you on a drop. And he looked at me and he said, Nate, I've never had a contact lens in my eye ever. I've never really had to put drops in my eye ever. I'm going to do horrible with eye drops. Is there something else that we can do? And I said, yep, we've got this laser again. This is in 2011. So I did a 360-degree SLT on him in both eyes, and it took his pressure from 28 and 25, 26 down to 19 and 18. So it had a nice effect, about 30% pressure reduction. And if you fast forward the next slide, this is his visual field 7 years later. Again, wow. We're hanging on, right? I mean, I have multiple visual fields on this, and the next slide shows his OCTs. And again, I think it gives us that even if we're a little bit non-compliant with eye drops, if he's on eye drops, or if your patient's on eye drops, we've got the peace of mind knowing the laser's in there and it's working 24 hours a day. And I think that's a big deal for a lot of these patients. I just had another patient, completely different one. He's 61. And we did an SLT on him in 2017. And then he was lost to follow-up for 4 years. We've got COVID in there, right, Paul? You ever had that patient? And he's a 0.85 to 0.9 cup in the right eye. I'm like, he's got advanced glaucoma in the right eye. I just sent him to a glaucoma surgeon for a combination cataract surgery and a MIGS procedure. But we look back and we go, thank goodness the SLT was done in 2017 before he was lost to follow-up for 4 years.
Kept him going. Yeah, man. These are great cases. And just look at that inferior notch there. And that really does correspond to the superior paracentral defect. This is an advanced glaucoma patient, but it's interesting, even though it's advanced and you didn't get his pressure down to 12 or 13, just the fact that you got him down, but stable at 18, stabilize him for a few years. That is a really good point. So sometimes we get so concerned about getting down to 12, 13, low teens as a target for advanced patients, but sometimes just getting them down and keeping them stable is enough to kind of halt the progression for a period of time. So that was really good stuff, my friend. I mean, I'm just going to stop sharing here because I know we have some live questions that we want to answer for some of our colleagues out there, but that was some great work, man. Thank you for all the insights that you had. Really awesome stuff.
Awesome to share the lecture podium, the virtual lecture podium with you, Paul. It's always a pleasure, and I look forward to let's get those questions.
Let's do it.
Hey guys, Nate, Paul, really appreciate your guys' time. What an amazing lecture, and couldn't be by two of the better people I know, man. I love hanging out with you guys and so thankful to have you part of Eyes on Glaucoma. So thanks for your time. Man, we had so many questions pop up in the chat box. We got 8 minutes. I'm going to try to get to as many as I can. But I know on that last case, Dr. Lighthizer, you talked about, that's your father-in-law. There were a few additional points you wanted to mention. Fill the audience in on those kind of additional points.
Yeah, so we started with SLT on him because he was very hesitant to go to drops. He said, I've never had a contact lens in my eye before. I'm not going to do well with drops. We started with SLT, but that wasn't the end of therapy. We had a nice, close to 30% pressure reduction for him, but due to his stage of glaucoma, we had to add other therapy as well. So again, factor that in. SLT may be first, but it may not be the last therapy based on their stage of glaucoma.
Paul, question for you. This popped up from someone in the audience. After 1 year, what is the effective rate of SLT?
That's a great question. I think I can tell you a gestalt. Earlier we treat, the better. So earlier, like first line treatment, we see studies showing from Gender and others about 80+% a chance of having significant efficacy out of those patients who respond initially. But if you look at a lot of data sets out there, even ones from 5, 10 years ago, about 60 to 70% or so should still say efficacious at about a year. But Nate and I were just talking earlier. The bottom line is, if it did work, and let's say it goes back up in the year, you can always repeat it. And that's a beautiful thing about SLT. If you had a good response initially, go ahead and repeat it again. And there's actually studies we can talk about, the COAST trial, which is kind of low dose SLT, kind of maintenance dose every year, just before it kind of goes back up, to kind of allow ourselves to maintain that efficacy over time. But the earlier, the better, but we do see significant efficacy even at a year out and plus.
I'm going to kick it over to you, Nate. Question for you. So comment on adding an NSAID for 5 days after SLT per the SALT study. This kind of popped up in the chat room as well.
Yeah, so I think there's a lot of ways you can go in the post-op management of SLT. We still put in brimonidine in office to just blunt that pressure spike. We'll check their pressure. But at home, as you said, NSAIDs, steroids, nothing. Our thinking has evolved over the years. I remember training with a couple of ophthalmologists back a decade plus ago, and they use nothing. And I think that's still not wrong that you could use nothing. Their comment was, if your eyes are a little red and sore and a little inflamed, good. I want them a little red and sore and inflamed afterwards. And again, I think that's okay. And I was also trained that maybe not a steroid. We want some inflammation there. Maybe we shouldn't pound them with a steroid. Would that limit the effectiveness? That's where the SALT trial, the steroids after laser trabeculoplasty trial, really gave us some good information. It had 3 arms. It had took these patients, and for 4 or 5 days after SLT, some of them got nothing, some of them got a topical NSAID, and some of them got a topical steroid. And it found at 3 months that the topical NSAID and the topical steroid had a little bit more IOP lowering than if you gave them nothing. So maybe that it keeps us on that inflammation track right where we want it. Not too much, not too little. So a topical NSAID or a topical steroid is certainly not wrong to utilize. We have lots of options. Paul?
And the patients are happy. They're not as inflamed, not as sore, don't have photophobia, don't call you in a couple of days. Are you sure? So no, I'm with you. I do the same thing. I think based on a SALT trial, I do use an NSAID for about 5 days.
Yeah.
Question for both of you now. And I'll throw it to Paul first. And then Nate, you jump in as well. SLT 180 degrees or 360 degrees?
If you look at the data sets out there, I mean, I think there's some data sets that shows that 360 might be a little better. And we don't know 180 degrees is better than 90 degrees in terms of efficacy and percentage of chance of getting a response. So I'm just a 360 guy. I'm going to do it, go all the way 360. The safety's there. And then if it doesn't work, I know, hey, I'm not going to go back up and worry about that. I'll just go ahead and do another sister session. If it worked and it goes back up, great. If it doesn't, I'll move on. So for me, it's 360.
I'm similar, 360. When I started doing this back in 2009, 2010, we did a lot of 180 degrees. Why did we do a lot of 180? Because ALT was 180 degrees. And as we were in the early portions of SLT, we did ALT this way, we should do SLT this way as well. But it really was the SLT med study in 2012 by Jay Katz out of Will's Eye. They did 360 degrees, and that started to change our line of thinking. And really for the last about almost a decade, we've been starting to do 360 degrees in POAG, ocular hypertension, low tension. The only times I'll dial it back a little bit is if they have pigment dispersion, pigmentary glaucoma. If the TM is just loaded with pigment, I will dial down the energy and dial back the degrees. A little bit more likely to get a pressure spike, and in some cases, severe pressure spikes in pigmentary patients if you overtreat in terms of degrees or your energy. So that's how I do it.
Real quick on that, I'm glad you brought that up. So for pigmentary, I'll still treat 360, but I'll not do as many shots per quadrant. So I think you have 2 options: either do less shots and only do 200 degrees, lower the power to 0.4, 0.5, or considering doing 360, so you're accessing multiple areas of the outflow system, but doing less per quadrant. So I think it's a great point you made. Sue exfoliation, pigmentary, those are all potential spikes. Absolutely.
Yeah.
So with about 2 minutes left, one more question. SLT in low tension glaucoma. And, I could throw this one I'll throw this to Nate initially here. Paul, please jump in as well. Is SLT an option for our low tension glaucoma patients?
I think it absolutely is an option in our low tension patients. You may not get quite the bang for your buck as you do with POAG and ocular hypertension looking at 25%, 30%, even 40% pressure reduction in some of those ocular hypertension or POAG cases. The literature shows it's about 14 to 16%, maybe 20% in some studies in low tension glaucoma, because we know the higher the pressure, the more likely our treatment, whether it's drops or SLT, is going to lower it more. But in low tension, again, it's a lower pressure. So again, 14 to 16%, maybe 20%. But Paul, I think it's important to remember one of the biggest beneficial effects is that diurnal curve, the diurnal fluctuations. I think that's a benefit as well. So definitely indicated in low tension.
Yeah, I agree. I mean, Lee, the study we're presenting is Lee, who showed us about 15% reduction. And the key is not just reduction of IOP, it's more getting people off of some of the medications if they're on meds, or preventing that fluctuation. We think in normal tension patients, spikes, even more than even POAG patients, can be more of a risk factor for progression. So for me, the thought of SLT is more stabilizing the diurnal and nocturnal curve, getting people off of medication so you decrease the compliance potential issues there as well. And then I use drug delivery too a lot in these patients if I'm trying to get them off of medications. That combination of SLT and drug delivery really does keep things nice and flat for those patients.
Thank you so much, you guys. What a fun conversation here to kind of end with. And you are two of the best. I appreciate your guys' friendship. Being able to have these discussions about, just making our patients' lives better. I'm blessed that you were able to join us on Eyes on Glaucoma. So thank you. And for everyone else attending, the raffle code I mentioned earlier is gonioscopy. And please join us in the exhibit hall for some closing remarks.
Awesome. This was great, guys. Congrats to all the organizers. Fantastic meeting.
Awesome. Thanks.